Hello, my name is Udayakumar Navaneethan, Fellow in the Division of Gastroenterology, Digestive Disease Institute at the Cleveland Clinic in Cleveland, Ohio. The article I am discussing today is to be published in Gastrointestinal Endoscopy, and it is entitled Duration and Severity of Primary Sclerosing Cholangitis is not associated with the risk of neoplastic changes in the colon in patients with ulcerative colitis. My co-authors include Preeti Venkatesh, Brett Lashner, Faiza Ramzi, Bo Shen, and Ravi Kiran. I felt that it is necessary to do this study as patients with primary sclerosing cholangitis, hereafter referred to as PSC, and ulcerative colitis, hereafter referred as UC, are at increased risk of colon neoplasia. Yearly surveillance colonoscopies are recommended in these patients, but there is only limited data currently available to support this. Also, the relationship between the severity of PSC and the risk of neoplastic changes in the colon has not been investigated. So the objectives of this study was to evaluate the time of detection of colon neoplasia in patients with PSC UC undergoing colonoscopy, and also to assess whether there is an association between the severity of PSC and the risk of colon neoplasia. Additional aims were to characterize the type and location of colon neoplasia and to study risk factors for the development of colon neoplasia in patients with PSC and UC. In an effort to better understand this, we conducted this single-center retrospective longitudinal study. Patients with PSC and IBD who required liver transplantation were identified from a prospectively maintained electronic data interface for transplantation called the EDIT database that accrues information on all patients who underwent liver transplantation at our center. Patients with PSC and IBD who do not require liver transplantation were identified using their PSC and IBD database. A total of 312 patients with PSC and IBD were identified, out of which patients with indeterminate colitis and Crohn's disease and patients with ulcerative colitis who do not have adequate follow-up at the Cleveland Clinic were excluded. Finally, a total of 167 patients with PSC and UC were included in this study. All these patients underwent serial colonoscopic surveillance for development of colon neoplasia or colon cancer according to the American College of Gastroenterology guidelines. The severity of PSC was based on the revised Mayo PSC risk score and the requirement for liver transplantation. The primary outcome of interest was the association between the severity of PSC and the time of development or detection of colon cancer and dysplasia, together referred as colon neoplasia, which is calculated from the initial screening colonoscopy performed at the combined diagnosis of PSC and UC. The risk of identifying colon neoplasia within the first 2 years of a combined diagnosis of PSC and UC was compared to that after 8 years of this diagnosis. Secondary outcomes included an evaluation of the type and location of colon neoplasia in patients with PSC and UC at our institution. Additionally, risk factors for the development of colon neoplasia in PSC and UC were also evaluated. So of the 167 patients with PSC and UC, 55 developed colon neoplasia at colonoscopy. The median age at diagnosis of PSC was 38 years. Patients with PSC and UC were followed for a median of 13 years with a range from 9.5 to 19 years since the combined diagnosis of both conditions. During this time, regular surveillance colonoscopies were obtained with biopsies. Biopsy detected colon carcinoma in 14 patients, high-grade dysplasia in 25, and low-grade dysplasia in 16 patients. Colon neoplasia tended to more commonly occur within the first 2 years of initial diagnosis of PSC and UC, with the incidence of 6.6 per 100 patient years of follow-up rather than within 9 to 10 years from diagnosis of PSC and UC, where the incidence was 2.7 per 100 patient years of follow-up. 10 patients who were diagnosed with colon neoplasia within the first 2 years of combined diagnosis of PSC and UC actually had a duration of use which is less than 8 years. On Cox proportional hazard regression analysis, the severity of PSC defined by the requirement for liver transplantation and a higher Mayo PSC risk score was not associated with the risk of development of colon neoplasia on follow-up. Old age at PSC diagnosis with a hazard ratio of 1.23 independently increased the risk of detecting any colon neoplasm on colonoscopy. The use of, interestingly actually, the use of ursodeoxycholic acid, 5-aminosalicylic acid, or 6-azathioprine and 6-mercaptopurine did not have significant impact on the risk of colon neoplasia in these patients. So our study adds the following to the existing literature. First, the duration and severity of PSC do not impact the risk of detecting colon neoplasms in patients with PSC and UC. Second, older age at PSC diagnosis independently increases the risk of developing any colon neoplasms. Third, colon neoplasms were distributed throughout the colon on colonoscopy, although there were right-sided predominance on colectomy. So, knowing this, what should be next? Given the high risk of colon neoplasia in patients with primary sclerosing cholangitis and ulcerative colitis, future prospective studies need to be performed to best diagnose neoplasia in these patients. Whether a white light high definition colonoscopy or the use of newer mucosal imaging techniques can detect neoplasia in these patients requires further prospective evaluation. So to conclude, patients with PSC and UC have a high risk of developing colon neoplasms as soon as coexistence of these two diseases is discovered. Annual surveillance colonoscopies in PSC-UC patients beginning at diagnosis is supported by this data. Older age at PSC diagnosis independently increases the risk of developing any colon neoplasms. Well, if you have any questions or comments, feel free to contact me, and thank you for your kind attention.